you so much for joining us today. And thank you so much for Scott and his Benefit Bump team for hosting this series. And we're so honored to be a part of it. We've just got a few slides here to kind of take us through what we feel are the key points in building out a comprehensive fertility and family building benefit, how it impacts your total employee population, particularly those who have been historically underserved with this topic. But on this first slide, I kind of just wanted to get everybody grounded in the notion of infertility as a disease state and the prevalence that it has, as well as all the other things that kind of go into it for everybody who's on the journey, whether you be a heterosexual couple, LGBTQ, single parents by choice, or anybody else who is trying to achieve their dream of parenthood. So a lot of people don't really know off the bat. You kind of get a feeling that it's around because most of us have friends and family members who we may or may not know that they've been struggling with trying to get pregnant and start a family. But the prevalence is actually 1 in 8. And it's pretty interesting that it's broken up very evenly between women and men. And a third of the time, it's actually could be both of the people in the couple. It's got a greater incidence rate than diabetes, asthma, or cancer. But along with it comes some stigma, and people feel, that it's not really a subject that is being talked about. But thankfully, with the increase in awareness and groups like Benefit Bump and Progyny, there's been more and more conversation about the need for supporting of these folks and what to do going forward, because it has not been routinely covered by insurance. We'll mention that in a couple of the statements in the coming slides. But typically we don't see infertility being covered comprehensively through traditional medical plans. Diversity and inclusion has definitely been a hot topic around the country for employers this year and last year with everything that's been going on. And it's certainly a space that infertility has a tremendous impact in. Most people aren't aware that Black women are actually twice as likely to experience an infertility challenge, yet half as likely to seek treatment. The way health plans have been traditionally written, LGBTQ folks and single parents by choice have oftentimes been excluded through how that coverage has been written. And we'll go into that in the next slide in a little bit more detail. And lastly, male infertility actually accounts for a third of the cases, like I mentioned, but for whatever reason, and being a man, I can certainly understand some of the hesitation around people wanting to speak about this condition, seek treatment for it, and otherwise, maybe just hide our heads in the sand. But what's actually really affirming and positive to find out is that, when males go in for treatment, it's very likely that they're going to be able to use their own sperm in trying to conceive and have that baby. While oftentimes people are really concerned about, well, is this really going to be the journey for me if it's not going to be my biological child? And obviously there's a lot of education that needs to go into that when we actually realize that whether it's our own sperm or not, the apple doesn't necessarily fall too far from the tree in terms of genetics and genes and things like that. But parents and children have a unique relationship and bond, no matter whether it's through adoption or through biological birth. Oftentimes these people are coming into this condition as their first major medical issue to go into. And most of us, we find ourselves trying not to get pregnant through most of our young adult lives, right? And when we're finally settled down and we're ready to start a family, and we find out that, hey, it's not going to be as easy for us as we thought it was going to be, and in fact, it's going to be rather difficult, it's rather shocking, it's frustrating, it's anxiety ridden, and creates a heck of a lot of stress for folks to try to navigate that. As if you can kind of put yourself back into that framework of having conversations with maybe your parents or your in-laws when you're first gotten married or settling down, and they're asking when the grandkids are going to come. Those are stresses that are kind of comical, and we kind of eschew a little bit, but those are really true stresses that people feel when they're going through this, whether it be, light conversations like that, or you've got siblings that, you want to have cousins who are around the same age, same with your close families, and all those sorts of things that we kind of take for granted. And people don't get the same opportunities to kind of really go through that. So it creates a lot of emotional stress which obviously has an impact to you as the employer in terms of their ability to work productively while being concerned about their ability to leave a family legacy. So women with high levels of stress are 29% less likely to become pregnant and twice as high with the risk of infertility. There's a large emotional, stigma that I mentioned too, where people don't necessarily oftentimes want to discuss it with HR or even with colleagues and things like that. Um, there is a big financial wellness component to it. So, at the same time, you guys are trying to address diversity and inclusion and your benefit programs. I know that you guys are trying to also address financial wellness as a huge component as folks begin their working years and building their careers. And infertility treatment is has a huge impact on financial wellness when most people have to pay for treatment out of pocket, or they're trying to manage a benefit that they're possibly eligible for, but that doesn't cover them all the way. They end up making some cost-based decisions throughout the course of treatment that might have adverse effects on their clinical outcomes, whether that being, transferring too many embryos in, which creates a multiple birth scenario, which leads to NICU stays, higher rates of C-sections and things like that. So the ripple effect is definitely wider and deeper than most of us really realize around the impact for infertility and the things that people are trying to do when trying to solve for that. I think, it goes without saying that, family building is really a human condition component that hits a lot differently than, if Winnie needs wisdom teeth taken out or a knee replacement so we can get back on the racquetball court. When people are looking to start their family, they're pretty driven to do so and will make some decisions that may compromise their well-being along with the success of the outcomes in general. So on this next slide, I really want to kind of just give you an example of some ways plan designs are written right now and how they exclude a lot of your population. So this is a very common plan design that you might see from a major medical carrier in your SPDs. And to be eligible for infertility benefits, having failed to achieve pregnancy after a year of unprotected intercourse, or after 6 months if the woman is over age 35, having failed to achieve pregnancy following 12 cycles, or 6 cycles, age 35 or over, or age 35 or under. These are typical kind of insurance-y things that companies do to try to help employers mitigate that claim risk by not having too many people utilizing a benefit if it's not deemed necessary. But these are really detrimental when we're talking about fertility and fertility treatment. All of these things, in fact, are really, impacting negatively on the woman's journey. But in reality, when you think about your LGBTQ community, this completely excludes their ability to participate in the benefit program at all, because you're requiring a diagnosis of infertility. And certainly 2 males in a couple may or may not have cannot have that diagnosis, excuse me. So it really automatically excludes them. And then as well as females who are thinking about being a single parent by choice, or they know that they may have some issues with their egg supply and they want to do some fertility preservation before they're ready to start their family, but aren't able to do so. So, Progyny and I think the rest of the industry is really looking to move well beyond these types of plan designs to enable anybody who's got a dream of becoming a parent, be able to do so and be able to access high quality care without being encumbered or constrained by insurance plan designs that create cost-based decisions throughout the course of treatment, maybe run out in the middle of a course of treatment, or like I mentioned, really exclude large swaths of people altogether. On this slide, we want to really talk about fertility coverage and what that means as an impact to your overall claims trend and spend. Studies have actually shown that in the states that have implemented coverage mandated for infertility have experienced cost increases of less than 1%. We recently shared a study from Resolve that also showed a similar statistic that said that 97% of employers who have implemented a fertility and family building benefit did not see significant increases in their claim spend and their maternity spend. So which is a really great indicator of the fact that, a lot of people need help out there, but if you can fold this into your medical plans and treat it just as any other disease with a high prevalence, getting people quality care increases their likelihood of having a successful outcome, whereby it decreases your likelihood of having high cost claims due to, poor treatment choices, and things of that nature. Affordability of treatment creates inequities based on income, and sometimes in geography. So oftentimes the plan design that I shared in the previous screen basically is a lifetime maximum benefit type of model where an employer will say, hey, you've got $25,000 as an infertility benefit should you meet all these criteria to take advantage of it. But what you're doing is, if you are an employer that's got employees, around the country, that $25,000 benefit doesn't go as far in New York City area as it might go in the St. Louis or Texas or Colorado areas. So solving for benefit inequalities just by way of geography is a way to kind of even out the playing field in that regard. Lack of coverage implicitly denies same-sex couples with access to family building coverage as compared to couples that are able to become pregnant naturally. So again, family building is really a key component, I think, to a lot of folks in this population. We're seeing more and more employer resource groups that are focused on LGBTQ. This is really, at the top of their priority list, trying to help their folks do what the majority of everybody else is looking to do when they're building their careers, right? Is to start a family, create that legacy, have all the pains and the joys of raising kids and sharing in that experience with their colleagues and friends and family. When we start to look at comparing the way that the progeny benefit performs as compared to the national average, we're really delighted to see that, because we're able to offer comprehensive coverage, inclusive of everybody, that is a value-based, utilization-based model, we're driving a 14% higher pregnancy rate per IVF transfer. We're lowering that miscarriage rate because we're including genetic testing in our plan design as not an option. So when folks are going through this and they're paying out of pocket, they might say, hey, that genetic test is about $5,000 test. Perhaps we're going to roll the dice on this because we're already into the whole treatment cycle for $25,000+, and it really becomes a cost-based decision that is going to lead to poorer outcomes, like I mentioned, because if you don't have a genetically tested embryo when it's being transferred back in, that miscarriage rate is going to increase significantly, as well as when you're deciding to transfer in embryos, multiple embryos that could account for multiple births. So we're really trying to focus on single embryo transfers and having full-term babies without any complications. So reducing the C-section rates and other things like that. So what can employers look to do when they're addressing inequity in family building? I think the first place to start is to check to see if you have a medical plan that is currently offering an infertility benefit and how the plan design is written. I think a lot of folks will find language that we shared in that second slide, where there's a lot of step mandated therapies, exclusionary language if you're requiring a diagnosis of infertility before you can get the benefit in place. So it's really making it difficult for the people who can actually gain the benefit to go through it successfully, and then also at the same time it's excluding quite a bit of your population. You can really look to also, when you're looking to support the LGBTQ family, a lot of their journeys to parenthood are going to be outside of the typical, artificial reproductive technology window, right? So adoption and surrogacy are key core components that employers ought to really strongly consider adding as a benefit. When I talked about, some sample costs of going through an IVF treatment being around $25,000 or $30,000, going through an adoption journey or a surrogacy journey is really a $100,000 or more kind of experience for folks when they're going through this. So, the industry is really lagging behind in this benefit. I'd say most oftentimes I see a benefit around the $25,000 amount for either adoption or surrogacy. So it's really only covering at best a quarter of the journey there. But what you got to realize is, in this slide, we state that, keep in mind that the percentage of your entire population that is going to pursue adoption or surrogacy is going to be pretty low. But the folks that are requiring that assistance, this is really a life-changing benefit to offer them, and a great way to foster inclusion, bolster your ability to attract and retain high quality talent, be recognized as a culturally competent organization, and all of those great things that make us feel really good about what we do on a day-to-day basis, being able to help and support folks who really need it. We think that the best scenario would be, from a bias standpoint, implementing a program like Progyny, where you've got a comprehensive fertility or family building benefit that supports everybody within your organization, those folks who are looking to do the egg freezing, those folks who are looking to do an IVF journey to get pregnant, those folks who are thinking adoption might be their best pathway to parenthood or surrogacy, and really enable them to have a concierge, personalized experience when going through this, not kind of just laying out, here's a bucket of money where you can access, but good luck Googling for to find a provider in your area, trying to self-educate around what the treatment options are going to be there for you, what the success rates and all of that stuff, but really ensuring that you've got a clinical coaching model with care navigation in there, with a team like BenefitBump who can really help you hold your hands from beginning to end, and being supported by a group like Progyny who can really take people into the weeds and get them through where they're going to be. Oftentimes in these journeys, you'll see people moving from IVF as possibly they run out of viable eggs, to try to create that pregnancy and move on to an adoption journey, or those folks who go up to surrogacy or things like that, and being able to have a single point of support for these folks as they go through that entire navigation of that long and arduous journey to parenthood. So a couple of quick things about what we're trying to do at Progyny, around removing inequalities and making sure that everybody who's got that dream of parenthood has a pathway to go through it. Equitable care regardless of income or geography, based upon or funding mechanism, right? So removing of that lifetime maximum model and going to a utilization-based, value-based program, where you're able to spread the risk across your entire population and enable everybody to go through a treatment model without being encumbered by having to pay out of pocket on their own that they don't know about, or being surprised by things that might not be covered throughout their treatment. Creating access to care regardless of path to parenthood, like I mentioned, for single parents by choice and the LGBTQ population, moving that dollar max model again to a more comprehensive cycle-based benefit is really what we're seeing helps drive the clinical outcomes. When you're able to go into your fertility clinic for that first appointment, you don't need to have your first stop be at the finance desk where they're going to ask you how you're going to pay for this, what's your benefit plan look like, are there any step mandated therapies, like do you have to go through X number of rounds of IUI before we can progress to IVF, thereby burning up close to half or more of the benefit dollars that you've got available, and including things like genetic testing, so we can also screen for monogenic disorders that cut across multiple segments of the population, sickle cell, Tay-Sachs, so whether you're Caucasian or Jewish or Black, we're really looking to increase the ability for people to see providers that have experience in helping folks like themselves get pregnant or become parents. So for Black people, they might be find more comfort in seeing a Black reproductive endocrinologist. For a gay and lesbian couple, I think they would be happier to be treated by a clinic that's got great experience in helping folks who are like them start their families. And again, really rounding in the coverage to not making it just about ART benefits, but also including adoption and surrogacy, knowing full well that those pathways are definitely pathways that a lot of people are going to have to go through in order to start their family. So those are the kind of the slides and the major themes that I wanted to bring up in terms of speaking specifically about inequality around fertility and family building. It's really enabling a benefit program to be accessed by everybody in your organization. Although they might have different pathways to parenthood, they would feel supported throughout the entire program and process. And also, like I mentioned, this is a benefit that hits differently. So we're so happy to report back feedback from our HR partners to say that, we get so many more calls and visits with tears of joy saying, hey, without you guys and without having offered this benefit, we never would have been able to have our baby and start our family. So the goosebumps that people feel when you get the recognition and feel a part of somebody's journey to parenthood is really overwhelming. It's a big reason why I really enjoy being here at Progyny. I couldn't get any more reward, I think, out of knowing the fact that I'm helping people become parents when they, maybe didn't have an opportunity to do so otherwise. And then we all get to share in the joys and the pain and the suffering. My kid was cute 14 years ago when we went through it, and now is an incoming freshman boy. Things are a little bit different, but nevertheless, my life and my wife's life would not, entirely be the same or as fulfilling if we weren't given the opportunity to have our son Cooper. So with that, I think, Sarah, we're ready for Q&A.
Yeah, and I'll just take a quick second to wrap up too, Winnie, but we just really appreciate you educating us on the pain points, some really good statistics about the pain and those suffering in these ways, and then walking us through just solutions and different ways that you can solve for various paths to parenthood, because there are many different ways and avenues to get there. And so really appreciate what Progyny is doing in this area. And when we help working parents connect the dots to make their lives easier and less stressful, we help them feel valued, included, and fulfilled, especially at work, and so they stay. BenefitBump, working together with Progyny, connects employees to their fertility benefits. Then we continue with them throughout their journey and understanding leave and pay replacement, connecting them to mental health resources, help them create return from leave plans, help them understand childcare resources and backup childcare plans, and create those backup childcare plans as well. So BenefitBump and Progyny working side by side ensures better outcomes for working families. And as you said, Winnie, absolutely, there's our contact information was on that previous page. Please reach out to Winnie or me. We would be happy to talk with you about how we can each, work together and solve for helping individuals and families create their families in ways that maybe they wouldn't be able to before. So with that, let's get to our Q&A with the 5 minutes that we have left. Kate, I will turn it over to you.
Yes, so we had a few questions that we received ahead of time, which actually I think, Winnie, you did a wonderful job of speaking to in terms of spelling out what a comprehensive benefit plan would look like. And then how Progyny is different from other fertility vendors. So those were already answered pretty thoroughly, and I appreciate that. We have a question that just came in the chat that says, do you have to be enrolled in your employer health plan to take advantage of Progyny's benefits? Can I be enrolled in my husband's coverage and still use Progyny benefits through my employer?
You have to be enrolled in your employer's medical plan if they are offering Progyny as a benefit in order to take advantage of it. The way Progyny works is we feel that, we're focused solely on fertility, and it's a great opportunity for employers to carve out that particular benefit for us to administer, because health plans are dealing with a whole host of other things that can really personalize and optimize that segment for success. But at the same time, we are fully integrating back into the health plan with regard to deductibles and co-insurance amounts. So you're enabled to keep intact your cost sharing strategies, and folks feel actually a level of comfort knowing that this is covered like any other benefit. So, and specifically to this question, hopefully, if you have only Progyny being offered at your employer, but you're not enrolled in your health plan, but you're enrolled in your spouse's plan at his employer, but that employer doesn't offer Progyny, you'd have to enroll to the health plan at your employer in order to access the Progyny benefit.
That's a really great, that's a great clarification. These benefits can be very complex, so that's good to know. One last question that I see coming through is, how do we create a business case for adding a new benefit like Progyny that does not have the same volume of potential users as something like diabetes or other conditions?
Yeah, there's really, kind of two ways you can look at this in terms of where your organization is in priorities and what you're focused on. I think there's a great attraction and retention story around offering a comprehensive and equitable benefit. It enables folks to kind of really tout their inclusive culture, their support around diversity and inclusion, and really tackle um, that feeling of loss. So, the scenario that I kind of pose to employers is, what would happen if your best salesperson and their partner were having trouble starting a family and you didn't offer a fertility benefit? Do you think that you would be at risk in losing that employee if they were looking for that benefit to be in place, so that they could take care of it? The loss of key employees is huge. The loss of mediocre employees is huge as well. But certainly, I think that's a big part of it. From a claims experience point of view, having a comprehensive fertility benefit can really help you mitigate those high cost maternity claims, reduce those NICU stays, because I mentioned when people are off on their own seeking fertility treatment, they're going to be faced with cost-based decisions, whether that be foregoing a genetic test that would require them to, possibly lose that cycle and have to start another one. So more cycles increase the cost for treatment, as well as, those folks, if they're going out having IVF treatment and implanting multiple embryos, and they're going to be coming back to your health plan with their twins and triplets. So they're going to, have those C-section births, those NICU stays, and those $1 million claims from that aspect. So I think from those two sides of the things, those are two great ways to create a business case: attraction and retention, as well as a better way to manage your claims expense in terms of maternity and pregnancy costs.
Thank you, Winnie. I think that's all our questions. I will say that is something I learned from your presentation today. I did not think about the idea of Progyny helping to decrease some of those claim costs by decreasing some of the risk factors associated with fertility treatment. So that was my takeaway today. Thank you.
Sure, absolutely.
Well, thank you for joining us, Winnie. Thanks, Kate, for handling the questions. It was great to see all of you on the call. We look forward to our next Equity in the Workplace series event next week. Winnie, thanks for joining us. Great discussion.
Thank you for having us. Thank you, everybody, for listening, and have a great rest of your day.